Hello, my name is Michael Hager, the Manager of Technical Assistance and Dissemination at the National Quality Center, and welcome to our Friday, June 23rd, End Disparities Learning Exchange office hours. It's a journal club, Getting to Zero, social workers as case managers on transdisciplinary teams improving the quality of HIV care in the United States. And this is based on an article that was written by Terry Fox, Adam Thompson, Donna Van Alst, and myself. And we're going to have our presentation today by Terry Fox and Adam Thompson, and I'll chime in a little bit, but we really want to hear from the wonderful experts in New Jersey who were the driving force behind writing this paper. And hopefully after that, we'll be able to engage all of you in a discussion around some of the nuances and some of the applications of this article in your own care setting as a provider, or if you're listening as a consumer, you know, we can go that way as well. Just before we get started, a couple of ground rules. We ask that you try to avoid putting us on hold. We're a relatively small group, so I plan on leaving the lines unmuted, but if there's a lot of unwanted disruption, I'm going to go ahead and mute your line. And if there are many lines that have disruptions, then I'm going to go ahead and mute all lines. To unmute your line, all you need to do is press *6. If you've just dialed in. If you have called in, if you've clicked in and you're looking at my face right now on the webinar, you can go ahead and unmute yourself by toggling the list view. So if you put your cursor over my face, you'll see a couple of icons appear in the upper right corner. Click the one that says list, find your name, and then click the little microphone to the right of your name. That little microphone will turn orange if you're muted, and it'll be gray if you're unmuted. Again, you can just bypass that if you want to use *6 to mute and unmute. The webinar is being recorded, and we're going to place the copy of the recording on our End Disparities Learning Exchange website. We're going to try to do that by the end of the day today, but considering it's a holiday weekend here in New York, it's Gay Pride, there might be a little bit of a delay until Tuesday. So please be patient. If you don't get the recording today, you will definitely get it on Tuesday along with the slides and the chat transcript for today's discussion. So before I turn it over to Terry, the last thing that I'd like to do, just to get a sense of who's joining us on the line and from where they're joining us, if you could go to the chat room and just type in a little bit of information about yourself. I'll start. Michael Hager, NQC, New York, and Disparities Leader. And again, this just helps to give us a sense of who's on the line and where you're calling from. We hope that we have a lot of folks interested and ready to talk about case management and transdisciplinary teams, and having a sense of where these folks are calling from is going to be helpful for us. So thank you very much. And without further ado, I'd like to turn it over to my friend and colleague, Terry Fox. Terry is with the Rutgers School of Nursing, and she's also very much involved in the Middlesex, Somerset, and Hunterdon TGA in New Jersey, which is basically where New Brunswick, New Jersey is, home of Rutgers University. Terry, turn it over to you.
Yay. Can you hear me?
Yes,
okay.
ma'am.
Yes. Okay, good. School of Social Work. I'm with the Rutgers School of Social Work.
Sorry about that.
Okay. I know there's lots of school nursing folks involved. So thank you. Thank you for the intro, Michael. You know, when Adam and Michael and I conceptualized this paper, we had this thought in mind, this idea that there are 3 elements that really make the idea of achieving getting to zero possible. And those elements are treating people medically and otherwise requires a transdisciplinary approach because of stigma, because disparity, because misinformation and fear about HIV represent significant barriers to this day. They still continue to keep people from getting treatment. Second, that in order to be successful with a transdisciplinary approach, social workers are uniquely qualified to unified disciplines. Social work itself has a long history of joining with people and partnering and thinking about things in a different way and breaking down barriers and working with marginalized populations. And then finally, to be successful in getting to zero, you have to have quality management. It's a required element in order to monitor patient outcomes and systems-level outcomes. It's hard to talk about progress without that. So we can go to the next slide. We have 3 learning objectives. We want you to be able to define what a transdisciplinary team looks like, and Adam's going to talk a lot about that. We're going to describe social workers' role in transdisciplinary teams, and hopefully we'll be able to explain how the combination of social work, transdisciplinary teams, and quality management will get us to 0. So that's just a quick background. Michael discussed it. Every year I go to HIV and social work. It's a really great way to talk to case managers and see how people are doing this work in other parts of the country. And as part of that, I was invited by Vincent Lynch, who puts that conference together, to think about if we wanted to submit a paper for the International Association of Schools of Social Work with UNAIDS. They did a joint publication this year to celebrate World AIDS Day. And so we worked on this paper from February of 2016. It took about a year for us to get it written and published, and it came out for National Social Work Month in March. There are a number of articles from different parts of the world that are represented in the publication. The link is there and as part of the slides, and I think Michael will probably make these slides available after. If not, we can email you the link either way. And ours is Chapter 10. There are 4 different chapters in that publication. Okay.
Thanks, Terry. Just some quick background. The link to this article and this paper resource is located in the Facebook meeting description. It is saved in the website meeting description, and it will absolutely be included in the email that we send around after today's call.
Thank you, Michael. Okay. So, I gave this presentation last month at the Global Alliance for HIV, Global Alliance for Social Service Workforce in HIV care and treatment. And they asked me to describe the national goals and priorities because even though a lot of the people in the room were American, they do HIV social work, they do HIV healthcare abroad, and they're not actually even familiar with the national priorities around HIV. So for those of you, this might be redundant or a little bit of a news fest, but please bear with me because it makes sense later on when we talk about transdisciplinary teams. So the national framework for HIV-related goals and disparities has been evolving for many years and has been periodically updated. As you all know, previously HIV prevention activities were separate from care and treatment, and we were very siloed and we did very different activities. They even have a different feel, I think, when you think about the way care and treatment is administered compared to prevention. Different funding, different staffing, different objectives. And this was problematic in terms of trying to get to 0 because we really needed to join together and think about being more strategic in terms of what we were doing, using our research, using our resources more effectively. Science research and years of experience in treating the disease has proven that treatment is prevention and has slowed the rate of HIV transmission. And so it makes sense that you need to include HIV treatment providers in conversations and activities that focus on prevention. And you really do need to make sure care and treatment teams who rely on prevention activities have a full understanding of what their goals are and really support them in helping accomplish rapid diagnosis and linkage to care. National framework for HIV-related goals and priorities have helped to organize HIV service providers around central and succinct premises for quality improvement. And so that's, basically the vision for the National HIV/AIDS Strategy that the United States will become a place where new infections are rare, that when they do occur, regardless of age or gender, race, ethnicity, sexual orientation, People will have unfettered access to high quality and life-extending treatment. Better for disease controls. Surveillance data shows that in 2015 there were 1.2 million people living with HIV in the U.S. The unified vision and goals are intended to reduce HIV incidence and to the extent that there are no disparities. The 4 goals are to reduce new infections, to improve access to care and health outcomes, reduce HIV-related health disparities, and achieve a more coordinated response. And so I'm gonna let Adam take over here.
All right, so this is a graphic that some of you may be familiar with, and it was disseminated around the time we were having larger discussions around new frameworks around our national priorities. And it was just to really make sure folks understood how much the landscape had really changed around the country in relationship to HIV prevention, treatment, and care. What you see here are some of the key changes, one of them being that the prevention toolkit has expanded. And as Terry was pointing out, as prevention started sort of integrating into care and we began using more biomedical interventions versus behavioral, you'll see that 2 key things occurred. One, the wide use and availability of pre-exposure prophylaxis. And while it's still in pockets of the country and not always accessible across all communities, it is showing a lot of efficacy in the communities where there is high uptake. Just today, there were some data published coming out of the United Kingdom that showed a sharp decrease in HIV infections in men as a result, they believe, of the widespread access to PrEP. But also understanding the role of treatment as prevention. For those of you coming from the systems up in the Northeast and for the rest of the country, you may be familiar with New York State's U=U campaign, undetectable is untransmissible, which is really trying to align this idea of treatment as prevention and really show the data and the efficacy. So we have new tools in our tool bag as far as prevention, which really affected our ability to be able to decrease incidence, kind of thinking in a different way. We also had the Affordable Care Act in 2008, which increased healthcare access and continued the process of healthcare sector transformation, particularly looking at the kinds of services in primary care environments that people living with HIV would need to access across systems beyond just their HIV care. We also have widespread and continued use of HIV testing. Right now we're looking at routine screening from 15 to 65, although yesterday I was at a meeting and I heard New York as well had changed that and took the cap up to 65, and we're looking to do more broad testing. So I think you might even see some new strategies coming down the pike as far as how testing is delivered as we think about testing in an environment where we're also actively battling stigma, because more things become possible the more the disease normalizes. Also looking at the care continuum outcomes, I think this concept of integration between prevention and care that really sparked our thoughts around transdisciplinary work did as much to change our thinking as the care continuum did, and I don't think I need to explain too much about that to those of you here. The other sector that's really becoming involved in our work that I think is really important for us to pay attention to as well is our HIV research community. I recently got involved with the CURE advisory boards, and I was really stunned by the amount of information that our CURE and research partners had about the disease and the progression of the disease, in particular for things like the cancers that we're starting to see in aging folks. So there's this whole trove of knowledge now contained in our clinical research that I think really has allowed us to, again, see the disease kind of in a different way and really begin thinking about things like the establishment of an HIV reservoir and how important it is to get somebody into care during an acute infection now that we have testing technology that can find it. So all of our national priorities really do reflect these updates in the environment. And even since this came out, which I believe is 2015, even more has changed since then. So it is incumbent upon us as providers and workers in the system to keep abreast of what's happening around us, because it is changing rapidly, not just the healthcare environment, but just the tools that are available to us in our understanding of the disease. And for those of you who have not seen it, I would highly recommend you check out the Undetectable is Untransmissible. It is a large conversation that I think people need to get engaged in. Next slide. So this is our jumping off point into the transdisciplinary system of care, and this graphic, we're really grateful to Terry because we had a really hard time finding a way to visually represent what we were talking about, and she found this graphic, which I think really does demonstrate. If you look on the left side, what you see is a list of services that are commonly used by persons living with HIV. I sit on a planning council. We just went through our prioritization process, and so we did a deep dive looking at each one of these items. And we can tell you that at the end of the day, every one of these are super important to maintaining an individual's access to care, as well as their ability to manage their own disease. And I think for us, as we begin thinking more holistically, these other kinds of services that really allow patients to not just benefit from HIV care, but to really look at all the other aspects of their health care that maybe aren't being addressed in an infectious disease specialty environment, but do need to be addressed. So it's this convergence of, holistic health care, supportive services, and all the things that we know that makes Ryan White work. But I think the difference here that we kind of put on the table and hope to kind of push people around how they work together, but in particular, how they work with their communities. Every day, more and more is pointing to this concept of population health and the idea that we care for a community of people. And when we do that, it really forces us to think differently, and I think this transdisciplinary model is a result of that thinking differently. And we want to make sure people know the difference, because it is a language game, to be completely honest. People will use these words interchangeably sometimes, and we want to make sure everybody kind of understands their very, strict definitions. So when you see here disciplinary care, you see the three colored dots. So imagine those are three different disciplines working together with a patient. But as you can see, they're not connected. So the patient or the client may be getting supportive case management from an AIDS service organization. They may be getting primary care from a primary care system and specialty care from their infectious disease doctor. But in a disciplinary model, they're not talking together. There's no sharing of data. There's no sharing of information. There's no case conferencing. There really is just this siloed look at the individual, and which means you're only kind of looking at your widget. So it's kind of that whole saying, a hammer looking for a nail, So in each of these environments, they're only looking at what their discipline has trained them to look at, because there's no one else in the room to stimulate them to look any differently. When you look at the next tier, which is multidisciplinary care, you can begin to see that there's some interplay between these folks. In a multidisciplinary environment, often the patient may see these individuals and it may be shared around a single record so that everyone is aware of what is going on, but that perhaps they're not discussing it. They're probably not talking about it. They may assign individuals to a team, and I put that in quotation marks because by team there, I mean just a group of individuals who are going to be responsible for their care. I don't mean team in the sense that they're integrated and working together in a way that we would kind of talk about team-based care today. When you look up one level, when you see interdisciplinary, as you begin to see the circles, they still have their shape. People still kind of know what they do, but they begin kind of like crossing into each other's territory. And for most of the Ryan White systems that I've seen around the country, most clinics, this is where they're functioning right now. It's somewhere between multidisciplinary and interdisciplinary. If a site is sitting down and let's say they're case conferencing and once a day they're meeting to discuss the patients or clients that are coming in, or it's a support service network and they're case conferencing around shared clients who may be case managed across support systems. While they're talking and they may be discussing, I think what is not happening necessarily is they're not presenting a united front to the patient or the client, but they're definitely not presenting a united front to the community. So from the community viewpoint, we're still seeing kind of three separate services in one place. But when you go one more up and you see transdisciplinary, that's really, I think at this point, the place that we're looking to go to, which is the circles, as you see, have disappeared. The areas of expertise now really blend in with one another. And in this space, teams, and when I use team there, I mean it in the way when we talk about team-based care, they understand their roles very well. They know exactly what their discipline does, and they can work in the gray space around where each other's scope kind of overlaps. But what it does is it allows the team as a unit to form a contract or an agreement or like a care, I think in social work we call it like a therapeutic alliance, right, with the patient, but they do that not as individual disciplines. So it's not me, doctor, talking to you and then go meet with the social worker and then go meet with the nutritionist. The idea is that your whole care team has come in to meet with you. And one of the interesting pieces I heard from folks, I asked people in an integrated model, they were telling me they had all these people coming in to visit the patient in the room, right? And I thought, as a person with HIV, wow, that's too many people coming to see me at once. It's probably overwhelming. And I said, what do you say to your patients? And the response I got was, we tell our patients that we're going to be wherever you are because you're the most important person here. And I thought, wow, what a way to like flip that around, and instead of, you know, talking about the number of people I'm seeing, saying that your team has got you, so we're going to be where you are, and where you are right now is in the patient room. And so I think when we look to move to this transdisciplinary place, it really calls upon us to merge disciplines conversations around what each other does. And I think Terry, I'm going to pass it to her in just a minute, she'll explain more about this, but it really does force doctors to think like social workers, and social workers to think like nurses, and you have all of those viewpoints at the table, and suddenly all of the needs are exposed. And I think the national priorities and our thinking about prevention and care as a single continuum is what has allowed us to bring this to this space. So I think it's a testament to the work people in the HIV community have done, but I think it's also a sign that social work interventions are working, and that social work interventions in clinical environments can potentially be the things that span that gap. So with that, I'm going to pass it off to Terry, who's going to talk to us a little bit more about the social work lens and how this all plays out in quality.
Thanks, Adam. So when you talk about implementing a transdisciplinary system of care, social workers are uniquely qualified to make this happen. Social work as a profession has a long history of joining with their parties, really. Social workers acknowledge and combat stigma, and they have for a very long time, and its impacts. The entire field is focused on recognizing and addressing injustice, social justice, and disparity. And social workers have a long-standing history with negotiating and mediating between parties, with recognizing and initiating change activities, coordinating and educating the public, facilitating change and promoting research in the field. And as such, when you look at the field of social work in general, it's very that to implement transdisciplinary activities is something that social workers are qualified to do and to lend oversight to the system of care. Next slide. And so then when you think about all of this and you apply it to roles in healthcare, social workers become instrumental in ensuring that patients have all of the resources that they need to treat HIV, to maintain treatment adherence, and resources to help promote prevention as well. Since healthcare, specific to healthcare, social work addresses the non-medical side of barriers, and it is social workers who focus on assessing the needs of person and environment. It is the social workers who promote stigma and the stigma-free treatment environments, although I would hope everyone else does that too, but it is also social workers who understand that it's necessary to partner with consumers and not direct them. It is also, in order to help design a successful treatment program, social workers also are responsible for measuring the efficacy of interventions to grow their understanding of best practices in the field. Okay, next slide, Michael. So this brings us to measurement. We talked a lot about measurement and the quality management process. And the quality management process has been used successfully in manufacturing for years to evolve, improve efficiency, and reduce error. And the concept eventually found its way into the medical care system, which is a good thing for us, that the medical care system would want to reduce error, medical error. It's underlying tenet of measuring the success of our national priorities. So we want to take a minute and talk about what a quality management program looks like. And there are other elements to quality management program, but this is just sort of a basic cycle that we use to, I use it to explain to everyone what it is that and what my role is, and the work that everyone does. In general, it is a series of discrete iterative processes that are intended to improve healthcare outcomes by making slight modifications to the way that services are delivered, measuring the impacts of those changes and responding accordingly. The first step is always to define what your indicators are. How are you going to measure your success? How do you define success? What would make the program effective? National priorities have helped define large indicators for patient care, linkage, retention, medication adherence, viral load suppression. These aren't the only indicators. I'm sure many of you know that and are working on quality management programs as we speak. But these are the ones that are related to our national priorities. And they're currently probably the most common among care and treatment providers across the country in terms of what people are tracking and what they're working on. The second step, after you've defined your indicators, is to detail how is your data going to be collected. From what elements of service provision are you going to examine what you're looking at? When and where are you going to record the information? What type of analysis will tell you if you're making progress or not? What is your current baseline measurement? How are you doing? What are your overall goals? Where do you think you could make? How do you think? What improvements can you make? To what extent? Then your next steps are going to be to collect and analyze the data and see if it tells you whether or not the intervention work. Do you need to continue? Do you want to stop? Then you're going to develop a plan of action and decide what your next steps are going to be. Are you going to expand the intervention that you just implemented? Are you going to change it? Are you going to scrap it altogether? And then basically you're going to repeat the whole cycle, take action and repeat the whole cycle. And here in the United States in the Ryan White program, we have the National Quality Center, which is an excellent resource and has helped me so much over the last 10 years. They are responsible for training Ryan White funded grantees who provide care and treatment. I'm sure all of you know that because you're on a National Quality Center call. Roughly 50% of people living with HIV in the United States are impacted by the work of the Ryan White program and the National Quality Center. And as part of the National Quality Center's teach effort, they led the national campaign, the In Care campaign, to increase clinic rates of viral load suppression. And if anyone has questions or comments or memories about that, we can talk about that a little more later. But the campaign yielded a catalog of interventions that were shared across sites. There were calls just like this one when we were doing that activity to address the issue and record the rates of viral load suppression at clinics throughout the country. And Michael can give you more details about how many and all that stuff. Our next slide is, so when we conceptualized this paper, I was like, oh, we should write this paper and it would be really neat. And then we sort of said, well, do we have any data that would really kind of help us back up what we're talking about here, talking about integrating social work into clinics and seeing if that has any impact on the quality of care that people get. And Michael and Adam were very confident that this data would show that. And so one of the things we looked at is the difference between the way clinics are structured and what their requirements are. Basically the idea is that clinics who are more transdisciplinary in nature, the ones who are more likely to have social workers on their team and the ones who are required to have more than just medical services to expand the services that are offered are going to have better rates of viral load suppression. And keep in mind, too, that this is, and the context of this is within the Ryan White program. So some of you in Part A programs are probably already thinking we already do that, and you do. There are even the smallest changes that reduce barriers, I think this data shows, makes a difference in the way that outcomes are experienced for people. So you can see here federally qualified health centers and community health centers have similar structures when they're required to provide services beyond medical care. Health departments, on the other hand, are only required to fund basic services and a very minimal level of care is needed. And then hospital clinics is kind of like depends on what the resources are. They provide a level of care that's less comprehensive than federally qualified health centers and community health centers, and they're not required to have a social service component, although they might. And patients will have access to other types of medical treatments in the clinics. So you can take a look at our graphs and see that even though there were improvements because people were involved in a quality management program, the improvements were bigger and a little more robust in federally qualified health centers and community health centers compared to other types of medical care models. The article that we wrote includes additional outcomes. We could probably have a whole webinar on those indicators as well. We just wanted to share with you this one because it's arguably, it's a very important outcome, and it's a goal that suits both prevention and care and treatment. One thing I have to say as a qualifier is that quality management data shows an expression of improvement. Part of all of those iterative process also includes improving data collection systems. So one thing we can definitely say is that we absolutely know what our viral load suppression rates are. In some cases, it's not always so obvious. I know there's a lot of struggle getting people to start thinking about collecting data and really working towards putting those systems in place. And that's definitely one outcome that's part of this process. So one thing I'd say is that this isn't research level data. You know, we can't do more rigorous statistical analysis. We can't say that it's cause and effect. But still, you know, I think that it's very important that if you're going to go through processes in terms of collecting data, you should look at it and do something with it and act on it and share it and think about what it means. You know, and then the other disqualifiers are that there's definitely some level of duplication because we don't track this at this isn't client level data. Collect it in aggregate and then share it with people. But we still think that there's an indication through this data that there might be something to think about transdisciplinary teams and really including social work and quality management and as a way to get to zero. And then the other thing is that the data, this data is based on like specific practices. So at the very least, transdisciplinary teams are in a better position to understand the scope and the limitations of their practice.
Yeah. You know, I think, Terry, one of the things that I would, you know, just kind of emphasize here, because you did a great job covering the limitations and also kind of what the overall, you know, findings or sense of the findings would be looking at the data, you know, just eyeballing this information, notwithstanding the limitations, because we're not a research program, so we don't need to be picture perfect and 100% rigorous. But you know, the point that you made, I just want to kind of pull out and highlight here, that the baseline and the end line for the more transdisciplinary teams are higher than those that are not set up to be transdisciplinary teams. So that's the one thing. But the rate at which improvement occurred was much higher, and you did say both of these things, Terry. But I definitely want to emphasize that you know, what we see here is that greater, faster improvement, even if your starting point is higher because of the nascent advantages that being part of a transdisciplinary team or you have more of that process in place is something that's really important to note here.
Thanks, Michael. Yeah. I want to say it again. honestly, when we looked at this data and we started to think about this, it was almost like Christmas because it was pretty exciting, I think, to see that the differences are that much bigger.
Yeah.
Yeah.
Terry, do you mind real fast if I just kind of show where this paper sits within the broader booklet of papers, just because I think it'll be fabulous. My friends, this is really excellent work here. As Terry emphasized, it involves folks from all over the world. It involves 18 different papers divided in 4 parts. So, you know, if you follow the link, if you haven't already, you'll be taken to this page. You can see there are 438 total pages. Lots of great information included here. And if I just navigate to where our paper lives, you can see more of the data involved or included further down, and also a little bit of a description in terms of who's involved, who's included in which of these different categories. I think that that's important context if you're interested in learning more, and also you can kind of see a little bit more in terms of where folks went with some of these measures. All right. Just wanted to kind of do a quick little preview there.
Thanks, Michael.
So, discussion time. You know, there's a number of things that are important for us to consider and to mull over in terms of the significance of this article and the thinking that goes along with it. And so I thought that maybe what we could do in our last 23 minutes here would be to see if you have any questions that you would specifically like to ask, but also to kind of, you know, rattle down this discussion list and to involve and engage all of you, because of course you have your own experiences in providing care or receiving care as a consumer in Ryan-White HIV/AIDS program recipient organizations around the country. So I think, and yes, Christine, I will go ahead and include that link right in the chat box. Boom, there you have it. So, Adam, oh, go ahead.
Oh, this is Dolores.
Yeah.
And I think that one of the clarification that I'm always seeking is, so this might just be a names game, but what is the difference between, or what is the specific key things that I need to take away as the difference between a transdisciplinary team and a multidisciplinary team?
Adam, do you want to do that? Or
and Adam, you might be muted, bud.
Oh.
There we go.
There you are.
Thanks. So I think that the key thing is really, what's interesting about it is, I think it's more how it's felt at the community level, to be honest, when you're looking at how the services roll out the door. So one thing that we didn't go too deep into here because it gets a little complicated, but I think it's kind of what you're getting at, which is what's the difference? Well, I think the difference is that, for example, if I go to the clinic that I'm co-located with at Kennedy Health Alliance, let's say I go in there and I consent to care. Right? I'm consenting to care. They give me rights and responsibilities. They give me patient grievance processes. They give me every form that I need. I sign everything. I get their care. Let's say that I also need psychiatry services. Well, then I'm probably going to get another care form that I have to do, another set of rights and responsibilities, maybe another assessment, and then let's say I need community-based case management. So then I'm going to go across town to my local community-based organization where I'm most likely going to have to fill out another set of rights and responsibilities, have another assessment. And I think people think that transdisciplinary means one assessment, and it does, but it also means more than that. It's one understanding of my expectations of that system of care, so that wherever I go, whether that's a community-based organization, the clinic, the psychiatry services, or even a food bank, my rights and responsibilities are the same in every one of those environments, and they're presented to me as the same in every one of those environments. So instead of aligning myself with a team that might be multidisciplinary at my practice, Kennedy Health Alliance, what I'm instead doing is aligning myself with the care that my community provides me, so that no matter where I go to get care in South Jersey, or even, let's make it even smaller, let's just say Camden County, that no matter where I go in Camden County, the expectations and the services that I will get are exactly the same at each environment, regardless of the institution, so that the hospitals even have to come together and begin those conversations around what does it mean to care for a community. And what the piece that I think makes it important is that not all environments, like Terry said, have social work integrated into them. And so what you're adding, what we kind of added as the special sauce, I think, in our paper, is not just transdisciplinary professionalism, but specifically the integration of social work as one of those disciplines. So it's kind of on two levels here. There's one piece that's the integration of social work, and then the secondary piece is the transdisciplinary practice, which is how you're supposed to function. So at the end of the day, multidisciplinary means potentially coordinated, but less collaborative. And I think when you get to transdisciplinary care, it's where coordination, collaboration are now so intertwined with one another that as a patient or a client, I see no distinction between the organizations providing me care.
Okay.
And there's a shared understanding of the goals for treatment.
Yeah.
So it isn't your goals and my goals that are separate. It's our goals that we're working on together. And the consumer is very much a part of that planning process as well.
And you'll even see some jurisdictions across the country. I've been doing a lot of research into care coordination, and what I find fascinating is that some of the jurisdictions are funding these teams, right? Like instead of funding an individual service or an individual like case manager, they're funding an entire system of people as one FTE team, and then responsible for all patient-level outcomes. So there's all kinds of different ways it's punching out in the systems, but I think if you look across the country, you're not going to find people calling it transdisciplinary, but when you look at how data are entered into the electronic health record or how care plans are developed, you're going to be able to see hallmarks of transdisciplinary practice in there.
And I think that's one of the really important points here in terms of thinking about this isn't just a nominal thing, and we're not trying to trick the community into looking at all of us as being the same, but no, we are literally the same. So I think one of the core questions that folks have, and certainly our federal partners were curious about this, were like, if I'm part of this bigger team and my FTE, is allocated as part of the function of this team, who's my supervisor? And as a social worker, there might be someone different than I've been accustomed to supervising me. And same for behavioral health, because again, this affects all disciplines. It's not just about social work supervision. It's about supervision in general of allied service providers. Do you have any sense or any indication as to how other folks have addressed this?
Well, I mean, I can, Terry, do you have anything? I can give you sort of what we're seeing down here. It's basically, so the missing piece and what we're actually trying to put into place that I'm working on right now as we speak is to bring supervision in for the social workers, because I think what's interesting is that mechanism of clinical supervision. I think it's something that's very common in social work, but I don't think it's as common in the other disciplines. I think that's more done in a mentorship role, which is slightly different. It's a little bit less formal. It's not as structured. But the social workers really have brought that concept of supervision in, so I think the fact that it's a question tells us the integration is getting closer, because you're starting to talk about things that are more social worky in nature. When you look at it, what happens is the supervisory model actually changes a little bit, I think, because when you flatten the hierarchy, like I think the assumption would be that the doctor runs the show, and that's just not true anymore. What we're actually seeing is that it's care coordinators who are really taking the reins of control here, which are most likely high-level RNs, like who've had a lot of experience in the system, or what we're also seeing are really experienced social workers also doing care coordination. So it seems as if the supervision steps out of a hierarchical supervision and actually moves more into peer-based team stuff. I think at the end of the day, as a system, you still have to have an HR department, you still have to have policies and procedures, all of the mechanisms of hiring, but supervision becomes less you do your job, and more how do we do our job. So again, it's like as a team, when you're working on a team, the team captain inspires you to work better as a team. They don't kick you off the team, right? So it's like you're in kind of a different place, but I think this is a critical question that I think systems need to be asking themselves, and if systems have good supervisory models in place, I think that's the time to be telling other people about how you're doing it, because right now, the only thing we're thinking to do is bring the clinical supervision in externally if it's not on site, and then what I'm seeing in a lot of practices is mostly there's a business side where a practice manager who's not clinical in nature but is more in the healthcare admin side, and they take over the policy procedures. Did you show up at work on time? Do you have the right time off? Did you submit this form? They do all that, but the actual team work and like your skills as a provider, those I think are done more peer-to-peer than anything else.
100%. Yeah, I think that would be, my sense too, speaking with different folks in the field, that the clinical supervision actually is more of a peer review process now that we all should be doing anyway. And it might be advantageous for a social worker to look at another care provider's, notes and to do peer review that way, because that helps with that seamless, integration of patient care. Because why would I look at other social workers' notes where we already have this strong bond and agreement and commitment to chart in a certain way? I should be talking as a social worker probably to a mental health counselor so that we can come closer together. And a physician should talk to a food service provider so that they can come together. 1502 really requires us all to do the best we can to measure clinical outcomes. And by forming transdisciplinary teams, it really leverages the ability of data to flow freely from a medical program into a transportation program, where a lot of transportation folks are kind of scratching their head like, how do I show viral suppression? This would be one way.
Absolutely, Michael. I think you hit the nail on the head right there. The example I often give is the food bank, which is suddenly I can measure the impact of access to food bank if, in fact, the social work assessment that occurred at the beginning identified food insecurity. Now, I may not ever be able to show causative, but I can correlate the two and be able to say there was a need, the need has been met, and now the patient is suppressed. And I think that was our challenge even in this paper, was how to isolate the social work aspect of it. And what I'm happy to say is that was really hard, because the teams are so integrated that now when you look at these outcomes, we're so used to A, B, C, D kind of thinking, very binary, that we have to even think about the way you evaluate this kind of stuff. Because if the whole team is functioning, then the whole team is accountable, but also then responsible for that outcome. So if it's good, great. If it's not, then the team comes together again. But I think you're dead on, Michael. If these teams aren't integrated, some of our supportive services, it is very difficult to demonstrate their value inside our system without these kinds of integrated connections.
Bingo. And in terms of thinking about, the second check mark on the list here, it's the one I just made. Is there flexibility and professionalism to allow for focus on all these different things that are important to the different groups, and then, of course, important to the patient, too. As you said earlier, the most important person in the room. I think that the key thing here is that by coming together and having an understanding of where our boundaries are and where the gray zones are, where we overlap with each other, allows us much greater flexibility, in fact, to meet all these diverse needs that the patient has and that all of our disciplines have, because we can better identify how we match up with or back up against another provider, and how we can, take care of one single requirement, issue, express need at a time. That's important to the patient, but then, of course, at the same time, taking care of all of our, our required work that we have to do as part of our professions.
Everyone's reviewing the notes. It's not your goal, it's our goal. So it's a different perspective than the interdisciplinary.
Susanna, do you have a question for us?
There's also one in the chat room there, Michael.
All right. So have you had pushback from physicians who often follow a more hierarchical perspective, and two, may have challenges in being reimbursed for their involvement in endeavors like this? And that actually gets at two of these questions here. I'd really like first to focus on that first piece, Adam and Terry. What do professional staff have to say about transdisciplinary professionalism?
I think with this is it. Gosh, how naked to be about this. So doctors have a really big problem with this. They do, but I think it's a generational thing, to be completely honest. And I think you have to understand how physicians were trained to understand their hesitancy here. And they're training, older physicians and providers were trained not to spread care like this. That in fact, when you have more individuals touching the problem, there's less accountability. And so they were trained that this was dangerous, right? But that's not how we think anymore, and we have more people on the team. So it's no longer this doctor-nurse binary relationship that it was for, a lot of medicine. They do have a problem with it, but unfortunately for them, the whole healthcare system is changing that way. And there is going to be no hierarchical environments left, to be completely honest, at the end of transformation. That's one of the whole goals. So whether they like it or not, unfortunately the change is happening. I think our job as advocates for this is to make that change as painless as possible. I think it's really making sure they see the data and understand that this is better patient care. Otherwise, the assumption that they believe is that a bunch of people are telling them what to do. The other concern they have is that their license is being extended to other people's work, and there's some concern that if someone does something under them that they'll be liable, which I think it's an unfounded fear, but these are just things I've heard from the physician community. I think there is pushback, but there are also physicians who are not pushing back, who are absolutely pushing this model. And I would recommend anyone who's looking for some good evidence on how this works, I would recommend you look at the American Board of Internal Medicine, specifically at the primary care practice run by the Sinskys, S-I-N-S-K-Y. They've been doing this a while in this integrated team-based model, and they are physician leaders in this. And I think you need to have doctors come in and talk to people, but at the end of the day, this is how healthcare is going. And you can make doctors unhappy, but you are doing no one any favors by letting them think that this environment that they've been working in is going to stay that way.
Okay, I just added that to the chat room. The other thing to point out here, Adam, building on what you said, is how is transdisciplinary professionalism funded or paid? Boink. There's this new thing coming out called CMS Bundles. And granted, yep, and while we have not been touched by that in HIV and AIDS, infectious disease yet, it's, common sense to think that, these big ticket items that are starting with really expensive services are going to touch us soon, because our services are expensive. When you think about the overall cost of the medical, or our economy, to treat HIV patients, granted, there are plenty of costs that are, centered within paying for medication and then paying for late diagnosis, repeat hospital visits, and whatnot for those folks. It is expensive. And the way that CMS bundles are going is that, one provider or a group of providers is going to get a blank amount, a certain amount of money, a set amount of money for serving a patient, and then that's it. So if the quality of care is good and there's not a lot of hospitalization and there's not repeat readmissions, then there's more money to kind of be spread around as quote-unquote profit. If the quality of care is poor and patients are going to the hospital multiple times, they have to change medications and be on salvage regimens, and all kinds of tricky things are happening that are driving up cost, well then the system is at risk of potentially losing money. And this is something that's relatively new coming out of the Centers for Medicaid and Medicare, and is exactly the way that we're going to be funding this.
Yeah, I would add to that, Michael, two things. One, I think if folks don't know what MACRA is and you plan on staying in healthcare, I think you need to go learn about it. It is the value-based payment process that's going to come about that will continue to radically change the way we fund care in this country, which is less about how many people did something and more about did the something they did actually matter. The other piece, just is to be aware of this, yesterday, the New England, actually, sorry, it was the 21st, 2 days ago, the New England Journal of Medicine published an article that looked at the demonstration projects in medical homes for federally qualified healthcare centers, and some of the things that came out of it that they recognized were that, one, the $6 per member per month fee that the demonstration projects were getting was not enough, that it actually needed to be more. and that they did see some increases in ED visits, which was supposed to be lower, but they've got some pretty good ideas about why that happened. But if you want to know a little bit about that money thing, there's that piece there. I think the other thing to really remember about funding in the Ryan White program is one of the most expensive pieces of this transdisciplinary process and these integrated teams is the care coordination team itself. And luckily in Ryan White programs, that's precisely what Ryan White pays for. So the most expensive piece that's keeping people from pulling off this model is actually something that we already have in our wheelhouse. It just forces you to restructure the way the supportive services go out. And thankfully, the way they defined the service categories in the notice update that went into effect in April for our Part A's, there's room in there to do that, to be able to fund these care coordination models, and we're seeing them all over the country. But I think the question is good to ask, and it is something we always need to keep our minds on. But if you're inside a big system, I think you're going to be hearing more about how expensive it is, but at the end of the day, people were really sick, and to get to health care, we're going to have to fix a lot of problems with sick care before we get there. So I think this expense might be an upfront cost until we get a wellness culture, and then maybe we'll see some less dollars, but there's no guarantee of that.
So we have about 4 minutes left. I
have just one question. Are there any examples that you know of where transdisciplinary model is being used and could inform other systems that want to move in this direction?
I would say you're going to find the closest places that are going to be pulling this kind of stuff off are integrated systems. I would look for places that have medical home models, places that are looking at it as accountable care organizations, those large-scale community accountability programs. They're going to be the closest to this, but I think, to be honest, if you want to see where it's going to happen, I think you're going to have to look outside the United States.
Okay.
I would look to the countries that I go to when I'm looking for sort of innovative and new models. Scotland has really great resources. New Zealand, which actually surprised me, has really good ones. Australia, and then I also look a lot to Canada.
Is that attributed because of the way the system is established in those countries where there is a uniformity in access to health care? Is that
I don't think it's so. It's not. I mean, access helps as far as the outcomes, I think, but as far as the organization of the care itself, I think it's because it is a government system. They can control the care models better.
Okay.
But I also think there's been more of a dedication to innovation in healthcare in the other countries because they're a smaller scale. They don't have the population size that we do. So what they're able to do in a country like New Zealand or Scotland can happen faster, which is good for us because it produces the data that allow us to inform our systems. But I think when you look at these integrated care models, they came to the U.S. from abroad.
Okay. Thanks.
So we only have about 2 minutes left, and thanks, Dolores, for kicking us off with that question. I'm wondering if others have some questions or comments, concerns about this model. What do we think?
Hi, my name is Daniel. Can you hear me?
Hi, Daniel. Yes, sir.
Hi, I'm a social worker at Lenox Hill Hospital in Manhattan. I actually work for our retroviral disease clinic, and within the clinic itself, just to be brief, we have psychiatrists, psychologists, nutritionists. Myself, I'm the only social worker, and we have a patient population of over 500 people. So it's I think it's a great model. I also had a chance to read some of the article, and I think it's spot on. And I think if more places were to incorporate this type of foundation and setting for patients, the quality of care, and reaching undetectable viral loads and just getting patients to a better place earlier will be much more manageable. However, with the lack of funding and resources, and I think there will be some pushback from providers, definitely when it comes to providing their license numbers and things, especially when you have patients being diagnosed in such late stages of the disease and they're so close to losing their life. How do you trust somebody when you're so used to doing things in this generational pushback, so to say? But I just want to say I appreciate what you guys were talking about today, and I'm going to look into a lot of the stuff that you guys were discussing and bring it up during our next staff meeting, because I feel that we're already doing this model, but we're just not speaking it and putting it down. But we are trying to incorporate a lot of this kind of care here at Lenox Hill Hospital.
Wonderful. You know, as part of the region here, you see that Adam, the presenter, is from the New York and New Jersey AATC. And so here's his email. I'm sure that there would be another local performance site that you would interact with at Lenox Hill, but perhaps Adam could help you interact with your AATC locally if there are any, you know, kind of thinking cap moments that you want to have with them, or if you want to just ask some questions.
Yeah, I think that would be awesome. And I think you guys are doing a great job, and appreciate the work that you all are doing.
Thank you so much, Daniel. I think we have time for one more question before we have to wrap up. All right. Well, on behalf of the National Quality Center, thank you so very much for your time and attention today. This is a really exciting topic that kind of dusts off an old chestnut, but presents it in a new way for us to think about the ways that we can leverage our own skills and our passions to improve the quality of care for people living with HIV by working together with other providers. Again, this was the last and final call for the End Disparities Learning Exchange, and I just wanted to thank everyone again who's been a faithful participant. It's been an incredible journey over the last 9 months. We have had over 1,000 people participate in all of our webinars. We've heard countless stories from the field of folks who have used measurement tools and intervention tools to make a difference in a real way in the patients that they serve their lives. And I'm just really inspired by you and your work and your dedication to all this. So thank you very much from the bottom of my heart for all that you do and for joining us today. And I don't know if Terry or Adam has anything they want to say before we sign off.
I just want to say thank you to everyone for calling in. This paper was really hard to read because it seemed really obvious and then also really hard to explain. Yeah.
Yes. Thanks all.
Thanks, everyone. Have a wonderful day, and thanks for all you do. Cheers.
Thank you so much.
Thanks. Bye. Have a good evening.
Bye.
Bye.
Bye.